Heart disease and HIV. Wow. I remember when I first started my residency, and were seeing patients with HIV, and they're all dying. Now, HIV patients, we have therapies that stabilize the disease. Now they die of heart disease, and that's really a transformation. And I encourage you, everybody, to read Anthony Fauci's autobiography. He has a couple chapters on HIV and the fascinating stories in there. And also I read those. What are those webinars we listened to about immunology? What are they called again?
Yeah, Microbe TV, and that's the channel's name, and they call it the series 12. They have lots of mini podcasts of virology, immunology, evolution, neuroscience, lots of things.
They did a really nice review on the story of HIV, and fantastic webinar. So I'd encourage people that are interested in science, interested in learning, and when in HIV we use the wrong biomarkers at one time. We don't have a vaccine. We're not going to have a vaccine at this point in time, but there'll be efforts to do that, and we have very effective therapies. So we now have the ability to actually stabilize the disease. But HIV is a very inflammatory state, and inflammation damages vessels, and one of the things can damage the heart. So the team has really put together a wonderful preparation. So tell us more.
All right, so first we'll start with a little bit of an introduction into HIV. Next slide. So HIV, or human immunodeficiency virus, is a virus that directly targets the immune system. Specifically, it attacks CD4 cells, also known as T cells, which play a crucial role in helping the body combat infections. If left untreated, HIV can progress into a more advanced stage called AIDS, or acquired immunodeficiency syndrome. At this stage, the immune system becomes severely compromised, leaving the body vulnerable to serious illnesses and infections. Unlike some other viruses, the body cannot completely eliminate HIV. This makes it a lifelong condition. However, with modern treatment options, people living with HIV can manage the virus effectively and lead long, healthy lives. Next slide. So this is just a bit of a review on the modes of HIV transmission. Next slide.
Actually, just backtrack a little bit. Tell us how the disease spreads and things like that, because I think some people worry about how do I catch HIV? Can I get it from a toilet seat? How do I have to, if I stand next to somebody, what's going to happen? I think there's a lot of myths there we learned. So tell us a little bit about that.
Sure. So the primary mode of HIV transmission is through bodily fluids. This includes blood, semen, vaginal fluids, rectal fluids, and breast milk. In the community, most common routes are through unprotected sex, sharing needles, and from mother to child during childbirth or breastfeeding.
And one other thing is anal intercourse has a higher transmission rate too, as well, compared to vaginal sex as well. So, but it's really remarkable. It is that if you actually control the virus status, you suppress the viral load, makes transmission very, very unlikely. I remember a study came out many years ago where sexual partners, and if you actually suppress virus, that the transmission was very, very low. So you're not going to catch it from anywhere, but from contaminated fluids or blood, etc. So and that's really something that we have to understand that. So thank you for sharing that.
Okay, so so the next thing we'll talk about is HIV and chronic inflammation. So in HIV, chronic inflammation is considered to be persistent immune system activation, even with suppressed HIV viral load from treatment. So causes for this include HIV persistence, which is like viral reservoirs in the body continuing to stimulate the immune system, microbial translocation, which is damage to the gut lining, which allows bacteria and their products to leak into the bloodstream, triggering immune activation, and co-infections, so other infections such as hepatitis or tuberculosis, which are common in people with HIV, can also add to inflammation. This continues continued inflammation can lead to damaged tissues and organs, which consequently accelerates aging and risks of non-AIDS related conditions. HIV infects and destroys CD4 cells, disrupting immune coordination. This results in reduction of CD4 cells and dysregulated and heightened immune system activation over time.
The CD4 cell, what are these cells? Tell us a little bit more about these cells.
Yeah, so CD4 cells are T helper cells, which are crucial for coordinating the immune response. So just reducing immune response in general is not a great thing to have.
So what we have is an immune system that has a non-specific response to any infection. That's sort of the rapid. Then we have a more sophisticated immune system involving T cells and B cells producing antibodies, and they work together. So the immune system is a very complicated part, and this affects a very complex part of the immune system. And it actually destroys the cells that are there to fight infection. And once these cells go away or get to a very low value, you can't fight infection. You get bad infections, and you get the AIDS virus. So it is complicated, but it's also amazing how we have this system that recognizes, your body has to recognize normal cells and abnormal cells, its own cells, cancer cells, infections, and the CD4 is one of those helper cells, or one of those cells that are involved in regulating your immune system. So truly amazing. We're not immunologists here today, but it's more complicated than most of us care to understand this, unless you're an immunologist. And keep telling us more.
Yeah, so next slide. So the consequences of this are increased risk of comorbidities such as cardiovascular diseases. So this could include arterial damage, higher risk of heart attack or stroke. It can also cause bone diseases, so reduced bone density or increased fracture risk. Also neurological complications such as cognitive decline and neurodegenerative disorders, and then also kidney and liver diseases. So additionally, we also see accelerated aging in HIV due to prolonged inflammation and immune system wear. So the next topic we have is inflammation and cardiovascular disease. So first we'll talk about the endothelium. So the endothelium is the thin lining of the blood vessels and lymphatic vessels. Keeping this lining intact is very important for heart health and disease because the endothelium helps with important tasks like controlling blood vessel relaxation and contraction, controlling blood clotting, cell adhesion, and regulating muscle growth in blood vessel walls, and then also responding to inflammation in blood vessels. Next slide. So endothelial dysfunction happens when the endothelium responds to inflammatory signals and then starts expressing molecules that promote inflammation, attract immune cells, increase blood clotting, and this leads to vascular damage and dysfunction. For example, some inflammatory signals that can trigger this.
Hold on, stop for a sec here. So we've got to talk about endothelium cells. So these are the cells that line your blood vessel. It's a single layer. Maybe you can just show that over there. So it's amazing how this group of cells has to protect your blood vessels, and if it gets damaged, penetrates, and it's amazing how important that barrier is. I always think about, you hear about the Trump wall or these walls that protect you. That is the crucial barrier between developing heart disease and stroke. If that next slide, please. If that vessel that one thickness cell layer gets destroyed or penetrates, it leads to heart disease. And so the theory about heart disease is that you have these LDL cholesterol particles that circulate in the bloodstream, and if they penetrate and damage through them, and that's the start of atherosclerosis. That's the belief of that. And a lot of things can damage that, from blood pressure, from smoking, from blood pressure. Infection is a really big source right now. And one of the things I learned in the last little while since COVID is that People who get COVID are 7 times more likely to have a heart attack, in the first couple of months afterwards. People who have influenza, other viruses, or damage that layer. And we know that taking the vaccine for the flu shot actually prevents heart attack. It's truly amazing. So, and this layer of protective cells, you want to protect it as much as you can. And so tell us a little bit, some of the finer details of that. I'm just so fascinated by this. Oh, tell us more.
Yeah, so we're just going to get into a little bit about the inflammatory signals that can trigger endothelial dysfunction. So this includes tumor necrosis factor alpha, reactive oxygen species, autoantibodies, and oxidized low-density lipoproteins. Next slide. So you already mentioned this, but atherosclerosis is a long-term inflammatory disease that affects blood vessels. It involves the buildup of plaques made up of cells, fats, and tissue debris within the inner layer of the blood vessel walls. Atherosclerosis is closely linked with elevated inflammatory markers, such as chronic inflammation, which plays a key role in the development and progression of plaque formation. So we'll kind of get into this a little bit. Next slide. Yes, thanks. So C-reactive protein, or CRP, is a key marker of atherosclerosis and a strong risk factor for coronary artery disease. CRP promotes atherosclerosis by increasing foam cell formation. So what this means is that it encourages macrophages to uptake LDL, which is like bad cholesterol, turning them into foam cells, which contributes to plaque buildup and narrow blood vessels. It also triggers the immune system's complement system, which is designed to fight infections, but when overactive, it can cause inflammation in the blood vessels. And it also reduces nitric oxide, or NO, production, which is a molecule that's produced by blood vessels that helps to keep them relaxed and open. So by interfering with production of NO, it leads to tighter, less flexible blood vessels. So yeah, this is important because it's not only a marker of inflammation, but it's also an active contributor to heart disease. And research shows that people with elevated CRP are more likely to have severe heart attacks.
Go backtrack a couple slides. Go backtrack a couple slides. This one more slide. Backtrack one more. So if you look on your left, you see this nice, beautiful artery. If you look on your right, you see this artery, this thin layer is being disrupted. It's being attacked. And this happens very, very early in life. It starts the day you're born. And we know by the age of 20, 75% of us already have destruction of this layer, damage to the vessel. Next slide, please. And what happens is the LDL particles or the virus, other area, or the bacteria, or it just damages that layer and it penetrates. Then you have your body's defense mechanism say, listen, we have LDL particles, we have viruses in these vessels, and they're damaging, and your body tries to fight it. And it causes a war going on. And we don't know what's going on. And you mentioned CRP. CRP, C-reactive protein, is just a marker for inflammation. It just means the battle's going on there. And we know that, for instance, just being overweight leads to higher inflammatory states and to problems. And and nitric oxide is the defense mechanism. The cells, the endothelium, secrete this protective substance called nitric oxide that keeps the vessels open. And foam cells are just a transformation of inflammation, this war going on. So unfortunately, we're living in a culture right now where there's so many wars around the world. But as we speak right now, all of us have a war going inside all our blood vessels. And the blood vessels that line the heart, if it breaks down, it has a plaque rupture, you have a heart attack. If it breaks down the neck, you have a stroke. Now it breaks down in your kidneys and damages your kidneys, but you don't feel it in different organ systems. So truly amazing what's going on in there. And so you mentioned this word inflammation, and HIV, because the virus, causes a very high inflammatory process, as you've shown us. So tell us a little bit more on the next slide, some of these cells here, and try to help people understand when you say tissue necrosis factor, what the hell does that mean? How do you translate to the average person? It sounds really good scientifically, but the average person doesn't quite understand that. I have trouble understanding all this immunology. It's taken me a long time to understand that. So tell us a little bit more.
Yeah, so tumor necrosis factor, or TNF, is another group of inflammatory biomarkers. So it's essentially a molecule that causes cell death and inflammation. So this is called necroptosis, which is on the slide right now. Basically, it's controlled cell death that triggers inflammation, which is, again, the keyword that we've been talking about a lot today. It also has a similar effect as CRP, so reducing that nitric oxide production. And again, this is important because it does play a role in conditions like heart failure, clogged arteries, and tissue damage following blood flow restoration after a blockage. Next slide. Yeah, so another thing we'll talk about today is interleukins, which are another type of signaling molecule. So two specific ones, IL-1 and IL-6, are known to promote inflammation and are linked to higher activity of the body's stress response system. Again, they are very similar in mechanism, so they reduce nitric oxide production, and they also increase the release of endothelin-1, which is a substance that causes blood vessels to tighten. So again, it's that combination of causing that vasoconstriction.
What's kind of interesting is the war goes on. You know, when you have before, you have tanks, you have your artillery, you have your cluster bombs, and you can see that you have, you know, the virus here is attacking, and you have all these cells in your body that are trying to defend itself. But unfortunately, a lot of friendly fire and a lot of casualties of different organ systems, and one is the heart. Tell us more. Keep going.
Yeah, so there has been research done into the role of inflammation in heart disease and how this could lead to new treatments that target these inflammatory biomarkers, which could help to reduce the impact of cardiovascular diseases. One treatment that has been widely studied is colchicine, which is used to manage pericarditis, which is inflammation of the heart lining, and prevent atrial fibrillation after heart surgery or other certain treatments. It works by reducing that inflammation and preventing the formation of deposits that cause that pain and swelling. Next slide. So we're just going to talk a little bit about the increased risk of heart disease in people with HIV. So HIV infection increases the risk of various cardiovascular diseases. It's believed to result from a combination of different factors. So like while traditional risk factors such as high cholesterol and smoking are definitely likely involved, research has also shown that the inflammation and the immune system activation caused by HIV play a significant role in raising risk of heart disease. HIV infection is linked to a 1.5 to 2 times greater risk of cardiovascular diseases such as heart attacks and coronary artery disease. This increased risk remains even in individuals who are receiving effective antiretroviral therapy. HIV-infected individuals have a higher risk of stroke and other cerebrovascular issues compared to those without HIV. And a recent study from a clinic in San Francisco actually found that HIV patients had a 4.5 times higher rate of sudden cardiac death compared to the general population. But it's unclear whether this is due to the ischemic heart disease or higher likelihoods of arrhythmias. Additional research also suggests that HIV increases the risk of peripheral artery disease and congestive heart failure, as well as a greater chance of developing atrial fibrillation in more severe or advanced stages of HIV. Next slide. So studies have also found that women with HIV are at a much higher risk for cardiovascular disease, with their risk of acute myocardial infarction being about twice as high as that of men with HIV. Although the overall rates of CVD are still lower in women, HIV appears to increase this risk more significantly in women than in men. The exact cause of this difference is not fully understood, but it may be due to higher levels of immune activation in women, even when their HIV viral load is the same as men's.
Yeah, so now to pivot a little bit and just talk about kind of what therapies there are for HIV. We're going to talk about the big class, which is called the antiretroviral therapies, or ARTs. So essentially, what is an ART? Or A stands for antiretroviral therapy. And so HIV itself is essentially a retrovirus, right? So it uses the RNA to kind of basically transcribe it into DNA. So it's going the opposite direction. So it's a retrovirus. There's no really cure for HIV. The best we can do is use these drugs to kind of suppress the HIV virus in the human body and to suppress it for as long as we can, and to make sure that we can't detect the viral load inside a patient's body. There's different kind of regimens that people use. There's 2 drug regimens, there's 3 drug regimens, and we'll talk a little bit about this a little bit later. But the reason that we have multiple drugs is because the virus can essentially develop a resistance, right? So we want drugs that target multiple different mechanisms at different stages in the life cycle of the virus in order to kind of prevent it from developing resistance and to adequately suppress this drug. So essentially, like we were saying, the goal of antiretroviral therapy is to maintain a good CD4 count, as well as to kind of suppress the viral load in our blood. And the goal is really to get an undetectable so that the viral load cannot even be detected by the laboratory's measurements. Essentially, it's used in many different contexts. It's used for people with HIV, but also used to kind of prevent HIV. So if you ever heard of PrEP or pre-exposure prophylaxis, that's something that you can take on a daily basis to prevent you and greatly reduce the risk of actually acquiring HIV. And there's even things like post-exposure prophylaxis where you can take it after you have an exposure to a possible HIV exposure, and then you can reduce the risk of acquiring HIV as well. So next slide. So there's a lot of different common classes of antiretroviral therapies nowadays. Probably the most common of these are the NRTIs, the nucleoside reverse transcriptase inhibitors, the NNRTIs, the non-nucleoside reverse transcriptase inhibitors, as well as the protease inhibitors and the integrase inhibitors. I would say probably amongst these 6, those 4 are probably the most common of all these drugs. And the exact mechanism is not the most important thing to think about, but essentially what they're doing is they're targeting different stages in the life cycle of the HIV drug. So for example, the NRTIs, what they do is they insert themselves in the section where they build this long chain of DNA. So they insert themselves there and they prevent it from keep building. Other things like integrase inhibitors, they prevent the virus from integrating into the human genome, and therefore kind of preventing the replication there, right? So each of these has like a different mechanism, and depending on the HIV virus, they may have resistance to each of these that are different. So it's kind of an art to try to figure out exactly which regimen is the best for each patient. And of course, each of these drugs have different side effects and associated with each one of them. Next slide. So how do we choose an antiretroviral therapy regimen? Well, essentially, kind of the traditional approach is to take at least 2 NRTIs and combine that with either an integrase inhibitor or a protease inhibitor. So one of the most common regimens that we see nowadays is, for example, what we call Biktarvy. This is essentially a combination of tenofovir alafenamide, which is the first NRTI. The second one is the emtricitabine. And then the Bictegravir, which is where the name Biktarvy comes from, that's an integrase inhibitor. And so this is a very common all-in-one, like a single drug regimen that's used very commonly to treat HIV in patients. Next slide. Now there's actually newer regimens that come out as well, which show that maybe a 2-drug regimen can be just as good as a 3-drug regimen. So this is a newer drug that came out called Dovato. And it's basically essentially just a single NRTI plus a single integrase inhibitor, so lamivudine plus dolutegravir. And of course, some providers still prefer Biktarvy just because they know about it a little bit more. But some other providers think that the less drugs, the better, right? So fewer side effects that are associated with it. And we'll talk a little bit about some of the side effects and cardiovascular side effects, especially of these antiretroviral therapies. Next slide. One thing that's of note is that Abacavir, which is an NRTI, there's been always a little bit of debate on whether this is associated with a higher risk of CVD. So it was kind of in the 2008 year when there's this study that came out that showed that people on this NRTI had a bit of an increased risk for MI compared to other ART regimens. Now, the subsequent studies that came out after this, it's a bit mixed. So about half of them show that there is a risk, half of them show that there isn't a risk. There's a big debate kind of over whether or not it does increase your risk of cardiovascular disease. But essentially, kind of the bottom line that most HIV physicians say is that, if they don't need to be on it, then we prefer another regimen, of course. But if there, for some reason, is resistance or something else like that, if they need to be on it, then it's better for them to be on this drug rather than try to avoid it due to fear of the cardiovascular risk. So next slide. So like we're saying, kind of the interplay of why antiretroviral of why HIV causes higher risk of cardiovascular disease is quite complicated, right? So there's the non-modifiable risk factors, as always, with all patients with cardiovascular disease. But there's also behavioral factors such as like smoking, use of other recreational drugs. There's the effect of, as we talked about earlier, HIV affecting chronic inflammation, affecting endothelial dysfunction and all that. The virus itself causing CVD. And also, of course, the drugs, right? The antiretroviral therapies, these can cause things like dyslipidemia, increased visceral adiposity, insulin resistance. So it's a very kind of complex interplay of both the virus, the drugs that are used to treat it, and behavioral modifications that cause this increased risk.
So one of the things is that many people with HIV smoke, which is probably such a terrible thing to do. Smoking is always bad, but if you're already at double the risk of having a heart attack or stroke and causing inflammation, smoking accelerates that process. So those with HIV, think about how to stop smoking. It's a priority. And we know some of the medications have different effects on the heart and also on fat distribution too as well. I'm not sure if we're going to talk a little bit about that tonight or not, but where you have fat and how it's redistributed with certain HIV drugs plays a role in future cardiovascular events. You can see there's lots of things going on in this thing. I think, this analogy of wars going on, and HIV is a nasty virus, but we can control now. We can't eliminate, but we control it, and that's an incredible feat. And I'll never forget, the start of my practicing people with Kaposi sarcoma, pneumocystis pneumonia. They died. And now we're living, and now we have to realize that because this chronic inflammation is still going on, heart attacks, strokes, and certain cancers are still a problem in the future. And so you have to be twice as good at controlling risk factors. And I'm privileged to know a lot of people who are HIV positive who are done extremely well. And but 30 years ago they would have died. So this is a modern breakthrough of medical therapy, and we have better regimens. And it brings a tear to my eye every time I hear things like this, because we can make we made such a big impact. This is one of the beauties of modern day medicine, and it learns, and we learn aliquots, bits and pieces over time. And what a remarkable journey this has been for this disease. And again, I'll encourage you to look at Anthony Fauci's book. Great advocate for HIV, and he's done a lot for this, and so many others have done so many things as well. So tell us more.
Yeah, certainly. I mean, like you're saying, Dr. Curnew, the drugs now we have are much, much better than they were before. I think even the first drugs that came out, like zidovudine, for example, AZT, that's the one that classically causes the distribution of fat, right? The lipodystrophy. So, for example, they look very, very gaunt. The fat gets redistributed to other parts of their body. But now we have better drugs that kind of prolong patients' lifespans, right? So now it's actually people with HIV, if they're treated early, if they have good viral suppression, their lifespans can be nearly identical to that of a patient without HIV as well.
I remember when I first started, we didn't measure viral load. We didn't know about viral load back then. And so we were measuring the wrong markers for disease. We did CD4 helper counts and ratios and things. And that just basically was showing the destruction the virus was doing. But it wasn't telling us how much virus you had in you. AZT I think was the first breakthrough drug that actually actually prolong people's lives. And what happened was that the disease came back because the virus mutates, and so you had to go more than one drug. That's why combination therapy is so important. But this was based on a series of multiple worldwide randomized controlled trials. It wasn't done by accident. It was done by good observation, good research, taking care of people, and learning in a progressive fashion. That's how medicine works and science works. It's a very progressive thing, and the disease has changed so much.
Certainly. So just a little bit more about kind of risk assessment for patients with HIV. So what we found is that, the classic risk score predictors, the estimators, for example, Framingham risk scores, or there's like the American Cardiology Association, they have their own risk score calculators. These risk scores, they consistently underestimate the risk of cardiovascular disease in HIV positive patients. So if you look on the kind of this bar graph on the right, it's looking at the 5-year risk in patients. And the red is kind of, the blue is what they predict based on the risk score. And then the red is actually the actual kind of observed risk that they find. And they find for patients of, most of the, whatever their risk is, for most patients, the risk scores underestimate their likelihood of having a cardiovascular event. Next slide. So now let's talk a little bit about managing our cardiovascular risk in HIV patients. So like we were saying before, back to this diagram, there's a number of things we want to focus on. Of course, the modifiable risk factors, like their behavior, their tobacco use, whether other recreational drugs, stimulant use, but also targeting, choosing an appropriate ART regimen, and also, maybe some therapies that can help reduce the inflammation caused by HIV itself as well. Next slide. So of course, there's for dyslipidemia, the biggest kind of evidence there is for statins, but there's some other research out there that suggests maybe there's some role for ezetimibe, maybe for PCSK9 inhibitors, but it's less well researched in that area. For the endothelial dysfunction, there's some research as well into looking at platelets, maybe antiplatelets, so things like ASA or clopidogrel, those kind of drugs. But again, the evidence for this is very scant, very loose. Next slide. So like we were talking about, and like Dr. Curnew mentioned earlier, smoking cessation is a huge, huge part of managing risk in patients, right? Studies have shown that patients who are HIV positive are 2 times more likely to smoke compared to their general population. As well, there's other recreational drugs, methamphetamine, cocaine, which have a huge strain on the heart, right? So trying to counsel these patients to quit smoking, even a little bit, and to reduce their risk is a big, big part of reducing their overall cardiovascular risk. The other thing is their weight management. So, the integrase inhibitors, which are a very, very big class, for example, the bictegravir or dolutegravir, it's very, very commonly used. But nowadays, we've seen that these classes of medications can actually increase your risk of weight gain. So as much as 5 to 10 kilograms in some patients. Each patient is different, of course. So this goes back to kind of reinforcing the general principles of lifestyle management, right? Using exercising more, eating less, and even for some patients, maybe using a GLP-1 agonist if they can afford it. And studies out there have shown that they're safe and actually even beneficial for patients with HIV. Next slide. Yeah, thank you. So, initially there was some concern over whether statins even work for patients with HIV. And this is kind of in the very beginning areas of research when we're starting to learn about HIV. But yes, studies have shown repeatedly that statins work at least as well in HIV population as the general population, if not even more. And so the studies that are here, the Intrepid trial looked at pivastatin versus pravastatin, and it showed that consistently they have a very good beneficial effect. Next slide. And this is the Reprieve trial, which is another big trial that came out. And it actually, for patients, we could talk about this a little bit later too, but essentially for this trial, they enrolled patients that were actually low to moderate risk of cardiovascular events. And even for these patients where statins might not traditionally be indicated, they've shown that pitavastatin has actually a very, very good benefit. And the trial was actually stopped early due to this benefit that they saw with the statins. So even for patients who are low to moderate risk, they have a very, very good effect.
So it showed a clear reduction in cardiovascular events, and probably better than explained by just the lipid change. It was probably decreasing both inflammation and lipids, but probably you can just see how important this class of drugs is for patients who have HIV positive. Again, the theory about inflammation being a role in many disease processes, HIV has a very high inflammatory process and clear benefit. So anybody who has HIV should be very aggressive in their lipid management to prevent heart attacks and stroke. It works. Tell us more.
Yeah, so there's also, like we were talking about earlier, GLP-1 agonists for weight loss, but there's actually some studies that show that GLP agonists such as semaglutide actually have a beneficial effect on reducing the inflammation in HIV-associated lipohypertrophy. So these are not necessarily clinical trials, but essentially they're looking at certain biomarkers of inflammation, and it's shown that these GLP-1 agonists are able to reduce them. Now, whether this translates across to mortality benefit or decreased incidence of major adverse cardiovascular events, there needs to be more research looking into it. But these are positive signals in the right direction that these drugs might be beneficial in patients with HIV as well. Next slide. So kind of an overview of the major pharmacologic options we have. So for example, we talked a little bit about using statins. There are some concerns over drug-drug interactions and the risk of myopathies. So for example, using some protease inhibitors such as ritonavir or cobicistat, which is essentially a booster for these protease inhibitors, we find that there is an interaction between these medications and most statins, but not all statins. So for example, this statin that they looked at in the REPRIEVE trial, pitavastatin, this statin actually shown to have no interaction with pretty much any of the antiretroviral therapies.
And this statin's not available in Canada.
Oh, is it? Oh.
But we certainly use atorvastatin, rovastatin quite nicely with good effects.
Yeah, like you're saying, still, despite this, most people still recommend using atorvastatin or simvastatin because it is a higher intensity statin. Although if there are concerns, you can always switch it and look at the exact mechanisms and interactions. On the topic of ezetimibe or PCSK9 inhibitors, unfortunately, there's just very little data on whether these medications are beneficial, although certainly I think given the other data, it's very likely that it's not harmful at least. And there's also kind of now interest in looking at antiplatelets because of all the endothelial dysfunction, endothelial involvement, chronic inflammation. There is some very kind of preliminary data in some small RCTs that look at some inflammatory markers of endothelial dysfunction that maybe ASA or clopidogrel can be beneficial, although again, these are not looking at clinical outcomes, they're looking at kind of biomarkers. So again, it's hard to translate this across to clinical practice, although it's an area of future interest for sure. Yeah, so that's basically a general overview of HIV and its kind of interactions with cardiovascular health. Thank you. And there's some sources that we list here, such as Katie, which is a great source for all things HIV, hepatitis C, if you wanted to learn a bit more. And of course, like we were saying, the Microbe TV is a really great source as well if everyone wanted to learn a bit more on this topic.
So I think HIV is a great story about a new disease discovery, spending time to figure out, what caused the disease, and then finding therapies in multiple clinical trials. There's been, for instance, a number of vaccine trials, different agents, some work, some don't. And it's remarkable what modern medicine has done. It's taken a disease that had 100% fatality to people that live productive and good lives and live long enough to get my disease, coronary artery disease. And back then, they didn't live long enough to have a heart attack or stroke. They died of their infection or of cancer. Now, we can do a lot to help. So the first thing about HIV is to prevent it from getting it. So having protected sex. If you have a partner who's HIV positive, know what you need to do. And once you suppress the virus, the transmission rate is extremely low. I'm not an expert with HIV. I'm an expert in cardiology and prevention. And at one time, I used to see a lot of these patients in clinic. Now I don't need to see them because all the HIV doctors are treating these patients with cholesterol medications and doing a good job. some people have a triglyceride problem that's more challenging to manage, and certainly these drugs make a difference. But there are many more choices at this point in time. So for an older physician like myself to see the transformation of this disease has been truly a breakthrough of modern day medicine. And this tells us is that medicine can do some wonderful things if you give the chance to do this. So I want to thank you guys for such an excellent presentation, excellent overview. And you can see that there are effective therapies to prevent HIV from taking your life, and there's also effective therapies for preventing some of the complications of HIV, heart disease and stroke, which can be decreased substantially by simple statin therapy. Wonderful. Any thoughts from anybody? Rad, what's your thoughts about this?
Yeah, while everybody was presenting, I had one thought which you kind of alluded to. How many patients we have seen in recent years, that you have seen in recent years with HIV, and you said not as much, and the HIV specialist, infectious disease specialist, seems like they're doing a good job, but that's something I was curious about, and how it's decreased in the past. You've seen more, and now not so much.
Yeah, they take over the management, and I get to follow a number of these people that are truly part of our family at this point in time, who who I'm just so glad that we have effective therapies, and that's just through modern day medicine, period. And a lot of smart people along the way, a lot of hard work from a lot of people that's transformed this disease, and we've transformed many other diseases. So I want to thank the team, and let's go prevent another disease, and keep working hard on this. Have a good night, everybody.
Good night, everyone. Thank you so much.